Afternoon, everybody. Are you ready to start again for your last slot of the day? Well done, everybody, for staying with us. So anybody that was signing up for this and hoping to hear Paula Yule speak this afternoon, apologies, she's not available, so you've got the understudy, I'm afraid. My name's Nichola Bennett. I'm the Adult Safeguarding Operational Manager for Suffolk County Council. I was hoping I wasn't going to have to use a mic because there was a lot less people in the room, but I think I've still got to do it because of the streaming. Yes, Amy's nodding at me. So, and I was hoping to use the roaming thing as well, but I've got no pockets in my dress. So I'm holding a microphone, which is very odd. I don't do karaoke or anything, so this is a bit weird for me. So I'm here to talk to you about sharing and escalating risk, and I'm going to be talking to you about a Safeguarding Adults review that was done in 2021. It was a Safeguarding Adults review for a lady called May Miller, and I'll talk to you a little bit about May in a minute. And May Miller is May's real name. Real names are being used because it was in the public domain, because it was reported in the press about what happened to May, and there was a coroner's inquest. So it's all public knowledge. The SAR that was reported and is published on the Safeguarding Partnership website includes May's real name and also the other person's name who was involved, which is a Mr. David March. And the families of both May and David were consulted about the Safeguarding Adults review, and they gave their permission for their names to be used. So just a little bit about Safeguarding Adults reviews for anybody that doesn't know. Safeguarding Adult reviews are undertaken by the Safeguarding Adults boards or the partnership in Suffolk. It's not the local authority's statutory responsibility under the Care Act, it is a board's responsibility. So I'm kind of here speaking on behalf of the partnership about the Safeguarding Adults review that the partnership undertook, not the local authority, although we were obviously involved in that. People are referred to the Safeguarding Adults Review panel to have Safeguarding Adult Review referrals considered, and the criteria for undertaking a Safeguarding Adults Review is when somebody has died as a consequence of abuse or neglect, and it's thought that there could be some learning from that review across multi-agencies. So it's not about single agencies, it's when there is a lot of agencies involved and somebody has died. It can also be undertaken when there is serious harm that's occurred as well, so it doesn't have to necessarily be about a death. So that just gives you a little bit of a context around Safeguarding Adults reviews for anybody that doesn't know how they work or when they're undertaken. I will keep looking down here because that's where my notes are. I don't rarely go into an office anymore, so I don't get a chance to print anything out. So I'll just be looking down here every now and again. So this is May. This is May Adelaide Miller. This is a photograph of May that was taken while she was living in a care home previous to the one that she was living in when she died. And this was a photograph that was shared with the press and featured in the East Anglian Daily Times and some other news articles when the incident occurred and when the coroner's report was concluded, when the inquest was concluded. So I just want to start by telling you a little bit about May. So May Adelaide Miller. May was born on the 2nd of May in 1924 in Hampstead in northwest London. May was the youngest in her family of 4 children. She had 2 sisters and a brother. And her schooling was interrupted when she was diagnosed with tuberculosis of the spine. So she didn't go to school very much because she had long periods of time in hospital when she was a younger lady. When she did leave school, she was employed as an apprentice dressmaker. And that was cut short, apparently, because of needing to go and help with the war effort. And when she was helping with the war effort, she went and worked in a ammunition factory. And when she was working at the ammunition factory, she met her husband. She married Reginald George Miller in 1947. They grew up in London. They lived in London together, and they brought up a family of 2 girls. She was employed at the local school as a cleaner and a dinner lady so that she could be at home with her family. It was said that in many respects May had a hard life. Aside from her own health issues, May was a widow for 36 years, and before the incident that we're going to talk about, she also lost her daughter 3 years previously to that. So when her husband died, she remained living alone in her flat in London, and most of the time that she could look after herself. Just going to scroll down my notes. May was described as somebody that had a strong personality. She was said to have overcome a lot of setbacks in her life, and she was a matriarch for the family. She had 2 children, 5 great-grandchildren, and 5 grandchildren and 10 great-grandchildren. And apparently over the years, they all liked to go and take advice from May. When she started to get a little bit older and age took its toll, she moved into a care home in Hitching in Hertfordshire to be closer to one of her daughters. Unfortunately, that care home ended up closing, so she had to move again, and she moved to Halesworth to be with her other daughter. And although her movement, as in her mobility, was quite restricted, she remained in good spirits and she had good mental capacity. May lived in London for over 70 years, and of 30 of those she was living on her own. It was said by her family that she was never attacked or felt threatened during that time of living on her own in London. And therefore it was very ironic that when she moved into a care home that was meant to be a place of safety, she was sadly attacked by a fellow resident with a walking stick. At the coroner's inquest, the coroner had concluded that although there were other health issues at play that caused her death, it was definitely precipitated by the attack that had happened to her at the care home. This is all information that has come from May's family. You can read this whole picture of May in the Safeguarding Adults review that's published on the partnership website. So I'm not telling you anything that the family haven't agreed for us to be shared. So what happened to May in that time at the care home? So 5 days after May moved into Beach House Care Home, and again we're using the name of the care home because it's in the public domain, she was attacked whilst in bed by a fellow resident called David. David had only moved into the home 3 days before the attack took place. David was sadly experiencing some hallucinations, and he believed that May may be posing a risk to the other residents in the care home due to his hallucinations. And that's why he went in her room and hit her with his walking stick. She went to hospital, and they had hoped that she was actually going to make a full recovery, but sadly she declined after a few days, and she died. And the post-mortem found that she died as a result of ischemic heart disease and acute bronchopneumonia. When the pathologist did the post-mortem report, he did though state that he felt that the attack had definitely exacerbated her current conditions and would have shortened her life. So I've told you a little bit about May and the sad circumstances of what occurred to May, but I think it's also really important that what we do is we describe David as well. So David was also part of this situation, and this is what David's family shared with us about David. So David lived a full busy life. He was in Essex and then also in Suffolk. His family described themselves as having a really fun and happy childhood with David. He was a design engineer who decided to leave that occupation and go and run a country garage until he retired. He was said to love tinkering with cars and motorbikes, and he had a passion for sea fishing. And apparently he liked to talk about his stories of sea fishing. He had a couple of friends he went sea fishing with, and apparently they had lots of adventures which they liked to talk about with the family and sort of regale these adventure stories of sea fishing. I don't know much about sea fishing, but I just imagine big waves and storms or something. Somebody might be able to tell me different if they know anything about sea fishing. But there was lots of mishaps and numerous adventures. He was great at DIY, and apparently he used to make lots of handmade wooden toys for his family, lots of which his daughter said that they still had to this day. He used to make them for his grandchildren as well. Dolls' houses, desks and fairy castles with drawbridges were made for Christmas presents. He took part fully in village life, apparently. He became chair of the parish council. He was involved in the drama club, and he painted scenery for many productions. Apparently, family and friends used to look forward to the many organised games and treasure hunts that he used to like putting on. There was musical gatherings where he would do lots of ragtime-style piano playing, even though he couldn't read music. When David's wife became ill with dementia, he was said to be a great carer. Friends in Halesworth, where he lived, used to say that it was really lovely that they used to see him still walking with his wife in the village, often holding hands, said to be a very loving couple. His daughter said that he was a wonderful granddad to his 4 grandchildren, and he had a new great-granddaughter, enjoyed cuddles with her before he died. Just to let you know then that sadly what happened was that David moved from the care home where the incident happened with May, and he lived there for a short time before he passed away. So before we talk about what we learned from the Safeguarding Adults Review, I just really wanted to give you an overview of May and David and who they are and who they were as people. And I think it speaks back to a lot of what we were talking about this morning, and I was quite reassured that listening to people talk this morning about, professional curiosity, and Margaret talking about the Capacity Act, and it resonated with a lot of what I'm going to talk about in terms of the learning from the Safeguarding Adults Review. But really what Margaret was saying about how key families are in giving a really good kind of rounded picture of people, and the context in who they are as human beings, and the context and environments in which they live. So that's May and David. So the Safeguarding Adults Review was undertaken in 2021, and it was a review in rapid time, which is a methodology which is used by by SCI, which is the Social Care Institute of Excellence, and really what reviews in rapid time enable people to do is to really look quickly at the information that they've got and pull that learning out really quickly. So there's Safeguarding Adult Reviews, a little bit like children's SCRs, the serious case reviews, can take quite a long time. You're building up individual management reports, you're getting lots of information from people, you pull it all together, you can have very lengthy reports, and what the methodology for the rapid review process is that hopefully we get learning quickly and we can start building on that learning and putting that learning into action. So May's SAR was a review in rapid time. So I'm just going to take you through the findings from that and talk about those in a little bit more detail before I go on to talk about information sharing and risk escalation and risk sharing, which is really what the main findings were. So what happened was that one of the first findings was that there's no way currently to report information relating to risk if a vulnerable adult has caused harm to someone who is not a vulnerable adult. In consequence, key information is not available to allow for full risk assessment. So just to give you a little bit of context about that, when where David lived before he moved to the care home was in warden-controlled accommodation. And there'd been some incidences in that warden-controlled accommodation where he had presented with some unusual behaviour towards the warden. And the warden had described it as intimidating, and she felt quite threatened, I think, by some of David's behaviour on those occasions, to the point that she'd actually decided that she wasn't going to go and visit David on his own, and that she wouldn't have him come. He would come to her office, and she didn't want him to come to her office on his own either. That information wasn't ever passed on when David moved into the care home. And what the Safeguarding Adults Review found was, in speaking to the people who were involved in what happened with May and David, was that because it had happened to somebody who wasn't a vulnerable adult, it didn't get written down anywhere. It didn't get reported as an incident. It was just something that had happened to the warden. She decided not to do anything about it other than stop the visits, but she hadn't reported it anywhere. It wasn't written down. It was mentioned in passing to family, so it was known, it was information that was sort of known about, but it wasn't formalised anywhere, it wasn't written down, and it certainly wasn't passed on to the care home where David moved to. The second finding was that there is a culture of task-focused approach by agencies in responding to a person's needs and risks. This minimises the chances that potential future risks are adequately identified in order to allow preventative measures to be put in place. And that's really about trying to look at people's care and support needs holistically. And this relates to what we were talking about earlier, in that professional curiosity is key. So I don't need to talk to you loads about professional curiosity now, because we had a brilliant presentation from colleagues this morning about professional curiosity. But it's just to mention that professional curiosity is key. So in the situation with May and David, when David was moving into the care home, it was almost like a bit of a tick box exercise was done. So the task was pre-admission. We'll do the pre-admission and we'll tick off that we've asked the right questions, and we'll move on to the next thing. But what that didn't happen was that professional curiosity and delving deeper to get more information. There was little consideration on that point around what the future risks were, and what was known about David's past behaviour. So had there been more professional curiosity to find out more about David's behaviour, perhaps future risks might have been able to be considered and preventative measures put in place. The third point of the findings was that when the service a person receives differs greatly depending on if they're funding their own care or not. This creates a disparity that sees full person-centred assessments only conducted for people funded by local authority, increasing the likelihood that self-funders' needs and risks are inadequately understood and shared between statutory sector, residential and other providers. So David was self-funding his care at Beach House. He did have a social worker involved, actually. There was a social worker who had been referred to, kind of almost like a light touch referral, and she had been sort of almost guiding and advising the family about how to go about supporting David to move from his warden-controlled accommodation to somewhere where he needed more support. But it was only sort of in an advisory role, and actually the social worker wasn't aware that he was moving. So she knew that he was being supported to move by family, but she wasn't actually aware that they'd identified a place and that he'd moved into that particular care home. So the information that was gathered, and there was no criticism of the care home. They did a good pre-admission assessment. There wasn't any criticism. And just to remind people that Safeguarding Adults reviews aren't about apportioning blame anywhere. They are about learning. And the care home were really great at participating fully in the Safeguarding Adults review to help us to learn what we could do. And they did say that it was limiting when somebody was self-funding, because you rely very heavily on the information that comes through from family members. And although we've said how great family members are in sharing information and how important that information is, we're relying on them heavily to share risk and to know what that risk is and to understand how important some of those previous behaviours might be. And they may not interpret that in the same way that a professional might interpret that. And that's why it's important to get the whole picture. Similarly, they did ask for information from the GP. Great, we think. We're going to get some information from the GP about some pre-admission information. It was extremely limited. And there was some discussion about the fact that David hadn't necessarily consented to full information being shared. However, there should have been an emphasis there, and I'll go on to talk about this in a bit, that the GP shared any information with the home that could have potentially posed a risk to other people. And that wasn't done. So in effect, what we're saying is, it might be difficult to achieve, but if somebody is self-funding, they should have the same holistic admission assessments that somebody who is funded by the local authority should have. And there shouldn't be barriers there to be able to access that information. There was some misinterpretation of the Mental Capacity Act, where what happened was that because David was seen as somebody who had capacity, it was almost like the responsibility was put on him and his family to identify and share risk. And it was almost like, oh, he's got capacity, therefore we'll just rely on him and his information to share with us. And there was some research done that found that social workers in a study in 2020 actually used the Care Act or the Mental Capacity Act to prohibit them sometimes from making their own assessments of a situation. I think it was a bit like what Margaret said earlier, is that, you know, sometimes what happens is that people, somebody's got capacity, therefore it's like, oh yeah, they're able to make their own decisions, therefore we'll step away and we won't do anything. And I think that relates to the professional curiosity. So, you know, oh, they've got capacity, therefore we'll rely on their information only and what they're willing to share with us, and that's good enough, and we won't ask any more delving questions. So what the findings said was that in a safe system, even where a person has decision-making capacity or where decision-making has been delegated, professionals need to understand and carry out their continuing duty to protect vulnerable individuals and prevent future harm. So, last finding from the SAR was, oh, I've gone really loud. In relation to older adults, it's too readily assumed that inappropriate behaviours are related to the onset of dementia without adequate examination of other possible explanations, and therefore risks minimised. And what the author found was that this increases the chances that people are left subject to sexual harassment or other abuse, particularly residential staff and residents who do not have the choice of removing themselves. And what the author said was that in a safe system, practitioners respond to behaviours that present risk regardless of whether these could be the result of mental disorder or other causes. So I think, again, it talks about a little bit what we were talking about earlier on our table when we were talking about the framework and about the normalisation of behaviours. So it could be that, oh, because some people with dementia might display certain behaviours, we don't then consider them to be as risky as if they were with somebody who didn't have that particular condition or that disorder. And that's a risk there if we do that as professionals. So we need to make sure that we consider the risk itself and not just attribute it to and dismiss it as part of somebody's condition. So what the Safeguarding Adults Review found was that there was a culture such that age, gender and assumptions about dementia can act as a barrier to practitioners directly questioning adults and their families about behaviour that has the potential to harm people. Okay, so just quickly wanted to touch on the coroner's findings as well. So the coroner for May's inquest actually issued a Regulation 28 report. So a Regulation 28 report are reports that coroners can do as a consequence of an inquest if they think that they can support organisations to action to prevent future deaths. So the coroner actually wanted to issue a Reg 28, acronyms, a Regulation 28 report in May's case because they felt that organisations could do more in order to prevent May's death. And this is what is recorded. Again, this is in the public domain, so I'm not telling you anything that you can't access on the darling internet. So the coroner was concerned that the GP was unable to disclose full information because of what they perceived to be data and confidentiality requirements, and I'll go on to talk about that in a minute. That at no time was the family of Mr. March asked to sign any letter to give any consent to access further information. She was concerned that there were multiple investigative agencies that may have been aware of the risk factors, but that due to him being admitted from a non-registered facility like a warden-controlled accommodation, that information was not passed on, or it was perceived that it couldn't be passed on. And I suppose I would add to that, and the coroner's thing to say, coroner's report to say, and what other questions were asked, and how, you know, what other information was asked for. So I think it was a bit of the information didn't get shared, but also the information wasn't necessarily asked for. And her view was that had there been a safe system for sharing safeguarding information between the wardened accommodation and the care home, there may have been an opportunity to safeguard May. And what we know is that safeguarding adult reviews will never be able to conclude completely whether something would have happened and actually totally prevented that person's death. We don't know if the information about David's previous behaviour, the fuller information that was included in the GP information about some of the concerns that family had raised, whether family had have shared that information, would that have prevented this awful incident from happening? The answer is we don't know. But what we do know is that the risk assessment and the risk analysis that would have been able to be done would have been much more robust than it currently was. And the care home themselves said, had we have known, would we have perhaps supported David to be in a room that was closer to the nurses' station so that we would have been able to keep an eye on him more? And I just think that's an example of something that could have been done, that may have. We can't say categorically, but it's just sort of worth bearing that in mind. So importantly, what have we learned from all of this? What have we learned? So proactive sharing of information is really, really important. Information needs to be relevant and proportionate and focused on risk. We're not saying that you share everything. You know, it needs to be proportionate and necessary. Again, relating back to this morning, professional curiosity and the importance of asking those delving questions. We had a lot on professional curiosity this morning, and that's great because that means that I don't have to cover it. Utilise sources of information. And again, this talks to what Joe and Nichola were saying this morning about the triangulation of information. Contact previous providers, contact health professionals, talk to family, but really talk to family. That picture of May and the picture of David that we got from the families after these two people had died was so much more thorough than any information that the care home had about either of them. And admittedly, you know, 5 days and 3 days, they hadn't been at the care home for very long, and that may be information that came afterwards. But how helpful it might have been to have known some of that information beforehand and got that richer picture might have then led to more questions, more information that was relevant to being able to assess risk. Full pen pictures, including people's care needs, their histories, and any inklings of risk included. So what I haven't said is that there's going to be a podcast regarding May's Safeguarding Adult Review, where Anthony and Paula Yule and Sarana Burgess from Norfolk and Suffolk Foundation Trust talk about the findings. And I put on there inkling of risk, because that's one of the things that Anthony says in the podcast. He made me not remember that he said this, but in the podcast he says any inkling of risk, you just share that risk. Don't think that it's not important, because if it's going to protect people from harm in the future, then share it, please. One of the things that people get really reserved about is sharing information. We know that people worry about breaking confidentiality. It's the patient's information. We can't share it. We need to get consent to share that information. So I just wanted to talk really quickly about some of the information sharing principles that help to support us to share relevant and proportionate information, just to reassure people that yes, we can share that information and we need to share that information, because how important that might have been to May and to David. Principle 1 is less relevant, but it just reminds people to justify the purpose of using the information. And this is your justification in these kind of situations. So this is the Caldecott principles. So for anybody who doesn't know about the Caldecott principles were introduced for public organisations to help guide them in making decisions about when and how to share information. Principle 7 is the one I've picked. I've got the link there, so you can go and have a look at all of the Caldecott principles. But number 7 is the really important one. It's the duty to share information for individual care is as important as the duty to protect patient confidentiality. Health and social care professionals should have the confidence to share confidential information in the best interests of patients and service users within the framework set out by these principles, and they should be supported by the policies of their employers, regulators and professional bodies. So I think that's really, really important to remind ourselves that we should have the confidence to share information in the best interests of patients, and what is more important in the best interests of patients than it is to protect them from abuse and harm. How much time? Okay. And just here as well is the 2018, the government produced information sharing advice for practitioners. It's aimed at children and families mainly, but it also touches on adults, and it's still completely relevant. So again, there's 7 golden rules. You can go and read all of the 7 golden rules, but I picked out the ones that were most related to the learning from the Safeguarding Adults review for May. So consider safety and well-being. Base your information sharing decisions on considerations of safety and well-being on the individual and others who may be affected by their actions. So if there is risks to other people that they are living with, or other people they may come into contact with, that's just as important, especially if they are vulnerable people too. Necessary, proportionate, relevant, adequate, accurate, timely and secure. Ensure that the information you share is necessary for the purpose for which you're sharing it, is shared only with individuals who need to have it, is accurate and update and shared in a timely way, and keep a record of your decision and the reasons for it. Whether you've decided to share it or not decided to share it, always really great to record the reasons why. And I think just in this document, it talks about the information sharing is essential for effective safeguarding and promoting the welfare of children and young people. And I would say that that is just as relevant to adults with care and support needs as well. So I'm quickly going to talk to you about risk assessing. I was going to ask you all to sort of sit and have a think about these 4 areas of risk assessing, but I'm not sure we've got time to do that, so I'll plough on through. So risk assessing, there's loads of ways that people can risk assess. If again, there's lots of research, there's lots of documents that support risk assessing and how to do it. But I think it fundamentally comes down to 4 key areas. And these 4 key areas feature in the references that I've put on there below. So it's risk in life context, risk perspectives from all involved, the weighing and the balancing of risk, and strategies for managing risk. So what do we mean by those 4 areas? So I've kind of combined the first 2 on this slide. So this is risk in life context and risk perspectives from all involved. And again, it speaks to the presentations earlier around professional curiosity and Margaret talking about mental capacity. So we've got our person in the middle. And what is it that we need to do? We need to gather their past wishes and their feelings. We need to listen to the person and their situation, gather that biographical information because it could be so key to understanding a person's behaviour and their risks, and speak to the people who know and have an interest in the situation. And I've sort of added the obvious ones there: family, friends, health professionals, previous providers, current providers, social care, but it's basically whoever is in that person's network. And this is where signs of safety is really key, because signs of safety promotes looking at people's networks, find out who's in the network. You find out who's in the network, you can find out who might have relevant and important information about that person. And I've just included a box there that I thought was quite sort of interesting in gathering that it sort of demonstrates the reasons why we need to gather that biographical information about someone. So Peter was alarmed one day when he was contacted at work by care services. They'd visited his mother at their home to find her cutting up the dress she was wearing. They felt this bizarre behaviour required urgent crisis attention until he reassured them that his mother had worked all her life as a dressmaker and cutting fabric was something she enjoyed doing. She had a box of fabric beside her and only needed to have a piece of fabric passed to her so that she could continue to do something that was meaningful to her. I just thought that kind of demonstrated the importance of getting that information. And what we find sometimes is that, you've got behaviour for people living in a care home that people get really, really worried and concerned about. And often there is a reason, particularly with people with dementia, there's a reason why they're doing that behaviour. And if we can find that out, we can help manage that risk in a positive, enabling way. So people that know me and have worked with me for a long time know that I have a phrase which is "it depends." When anybody asks me about a situation, I very often will go, "It depends." I think it's so key with safeguarding because there's so many scenarios and situations that people find themselves in where there is no one answer. And that's why I think finding out about individuals and the context in which they live is so key. So one of the other things I always talk about is not only it depends, but context is key. And I think, you can see that from what Sarah just did with the framework. So you get a scenario and you go, well, I might do this, and I might do that, and I might do the other. Again, this morning with the professional curiosity, and you've got the front door, and what would you do next? Well, it depends. Depends on the situation. So find out the context. Find out the context in which people live. Is 4 a lot? Well, it depends on the context. $4 on your account? No. 4 hours left at work? Yes. 4 minutes left of this presentation? Maybe. It all depends on the context. So that's why rich information is so key. So just quickly talking about weighing and balancing risk. Again, there are many ways to weigh and balance risks. There are many ways, but they are usually all tools that you might find generally are based on the likelihood, the severity and the impact of the behaviour that poses a danger to someone. So what I've included here is the Signs of Safety Harm Matrix. And again, it talks mainly about children and young people, but we're a partnership and there's so many of these things that are transferable across children and adults. So we use this in the central safeguarding team in the local authority. We really like the harm matrix, find it really useful way of setting out the information and trying to weigh up what the likelihood is, what the severity is and what the impact is. And just thinking about May and David, perhaps had that information been shared, then the care home, alongside the family, alongside David, would have been able to look at that behaviour that had previously been displayed, mapped out like this, in order to meet a strategy for managing that risk. And again, strategies for managing risk. What are they? It depends. It will all depend on the situation. And all you can do is work with the person, work with the people involved with the person in order to plan and try and manage that risk that's going to enable somebody and hopefully promote positive risk taking. But fundamentally, whatever we call it, whether we call it safety planning, management plan, risk assessment plan, enablement plan, whatever kind of plan it is a strategy for managing risk. And it needs to identify what the person will do, what the staff will do, what others will do that are important to the person, and then it's a negotiated safety plan. And that is about sharing risk, because none of us can do this on our own. We all need everybody to take responsibility and accountability for that risk. It's not the local authority's risk, it's not the police's risk, it's not the person's risk, it's all our risk in order to try and safeguard people. So just want to make sure that what we do is we make robust and good decisions. Again, going back to what Anthony started the day with around this is about decision making. And as long as we use reliable assessment methods, we make sure that information has been collated thoroughly, that it's been triangulated, then what you have is defensible decision making ultimately. And I shall say, thank you very much for listening to me. It's the end of the day. I always like to end with a dog. Sorry if you're a cat person. I'm a cat person as well, but dogs just float my boat at the moment. So thank you ever so much. If you've got any questions, let me know. Oh, no, I'm going to take it round. I don't mind.
Has anyone got any questions? Yeah?
Oh, no, really?
Just going back to May and David, when you said the previous accommodation hadn't shared that information, whose responsibility would it have ultimately been would it have been the new care home to request any information, or would it have been the previous accommodation to offer up that information, or is it joint?
I think it's everybody's responsibility. So, and I think that's it kind of comes back to the presentation as well, whereas somebody thought that nobody was, know, I can't remember exactly how it goes, but it's that thing where it's like if you assume somebody else is doing it, don't basically. So I think what it found was what the review found was that the provider, the warden accommodation should have shared that information once they knew he was going and moving elsewhere. And what happened was that nobody asked the question about why. Well, they did ask the question about why was he moving, but the answer was increased need. So it was like, oh yes, he's getting more frail. He's had a few hallucinations. We're not really sure what's going on. It might be dementia. So he needs more support. And it wasn't delved into more. Nobody said, but okay, so what were those incidents? What did they look like? Have we got any information? Turns out he'd called the police a couple of times because he thought that somebody was looking through his window, and he'd had some quite paranoid thoughts, which then obviously looking back and having that information, him thinking that other people were at harm from May, and he thought he was protecting people. There were obviously some paranoid thoughts going on there, but it was like, yes, he'd had a few hallucinations. We're looking into it. That extra information wasn't asked for, but it also wasn't shared. So you've got, it's no one person's responsibility, I think is what I'm saying. It should have been everybody's. Everyone should have been clawing at each other to go, I think we need to consider this as a risk, actually.
Yeah, we find that very much, as you touched upon with the self-funded clients, that it's very difficult to get any information when someone comes to us as a provider to get any information. Sometimes the family won't want to give you any information why they've had to leave the previous provider, and we don't get any information, and then things start to unravel then.
Yeah.
So it is very difficult.
And I think as well, the care provider probably thought, oh, they're self-funding, so there's not a social worker involved. So don't presume that either. Give the local authority a ring. Is this person known to you? Is there any information that you think is relevant to share with us? And if you can get permission from the person and get their consent, then absolutely that's the best thing to do to start with. But if there is significant risks that the local authority know about, and you don't have their permission in order to safeguard them and other people, then like we've said, that should still be shared. Yeah, and I think it's one of those things where it's like, it's always most professionals would rather defend their position of having shared that information in good faith with good reason than they would stand up and try and defend why they didn't when there's significant risks, or as Anthony said, an inkling of a risk.
We've had no questions through from online, but Sarah had said, having worked for many years in acute care and A&E, this kind of information is sometimes not shared or takes time to be shared within hospitals and in emergency admissions.
It's always harder, isn't it, to share that information in an urgent situation. And like I say, 3 days and 5 days, they hadn't been at the home very long. And I think because David and May moved into that home pre-COVID, I think there's something about the rapid movement of people from hospital during COVID times as well, where people were moving a lot of people were moving quite quickly in emergency situations, trying to move people out of beds in hospital. And there's a slight fear of mine that I think, how much information was actually gathered in those situations when, and it's always going to be difficult when it is an emergency situation as well.
Thank you. Is there any other questions for Nichola? No? Any other thoughts?